I'm Dr. John Stone, a professor of medicine at Harvard Medical School and a rheumatologist at the Massachusetts General Hospital in Boston. Patients have often heard that steroids need to be tapered, that they shouldn't be stopped abruptly. In contrast to the moon phase and body fat redistribution that we've discussed, which begin to occur early, the effects of adrenal insufficiency aren't perceived by the patient until later, when patients are toward the end of their prednisone taper and maybe see the light at the end of the tunnel. That's when, unfortunately, the symptoms of adrenal insufficiency can begin. This is because the use of steroids for therapeutic purposes suppresses the patient's endogenous production or the patient's own production of glucocorticoids, which we need for normal function. We all make steroids or glucocorticoids normally. They are essential for many aspects of normal body function. Humans make glucocorticoids in glands which sit right above the kidneys, known as the adrenal glands. And we all make the equivalent of about 8 milligrams of prednisone a day in the form of a hormone called cortisol. The production of cortisol is controlled very tightly by feedback loops. So when the body has enough glucocorticoid, the production of the body's own cortisol by the adrenal glands is decreased. When patients are taking prednisone to control inflammation, the adrenal glands downregulate their own production of cortisol. And it takes the adrenal glands days to even weeks or months to ramp back up their normal cortisol production levels. And this is when the symptoms of adrenal insufficiency can occur. Therefore, when patients are on a prednisone taper and they get below the body's usual threshold of steroid, they may begin to have symptoms of adrenal insufficiency. And these symptoms of adrenal insufficiency can pose a difficult conundrum for clinicians as well as patients, because the symptoms of adrenal insufficiency may mimic some of the symptoms that the patients had earlier when their inflammation was active. Patients can be fatigued, they can have morning stiffness, difficulty raising arms above their head. It can be difficult to differentiate the symptoms of adrenal insufficiency from those of the underlying problem for which patients were treated with steroids to begin with. Now, the typical approach to avoiding or treating adrenal insufficiency is to taper steroids slowly, to allow the adrenal glands to slowly wake up from their suppression, so that as the patient begins to get below 8 milligrams of prednisone a day, the adrenal glands are responding and making a corresponding amount of cortisol so that patients don't feel these symptoms. This is a tricky balance to achieve, and it sometimes takes more than one attempt, the closer one gets to 0 milligrams of prednisone a day, to get the daily dosing right. And if the patients develop symptoms of adrenal insufficiency, then the typical response is to increase the dose just a little bit so that patients don't have these kinds of symptoms, and then to continue the prednisone taper again, but even more slowly, to allow the adrenal glands to recover. I sometimes find, because it is difficult to differentiate the symptoms of adrenal insufficiency from those of the underlying condition, it's sometimes helpful to involve an endocrinologist in the discussion to help determine if the patient really has adrenal insufficiency or not.